Hello, medical. Good morning. Namaskar to everybody. Myself, Professor G.R. Patel, Professor of Surgery and Head of the Department. Today we are going to discuss about esophageal atresia, a congenital anomaly which come across by general surgeon, and that is why the lecture is being delivered here. Tracheoesophageal fistula is a serious emergency which has to be tackled on emergency basis. The general surgeon should have the knowledge and skill to repair the defect. Of course, where the institution is a pediatric surgeon, it will be repaired by a pediatric surgeon with due care. Esophageal atresia is a congenital anomaly in which there is complete interruption of the lumen of the esophagus in the form of a blind upper pouch, generally associated with a tracheoesophageal fistula. There are two main anatomical types, but a blind proximal pouch with a distal tracheoesophageal fistula is the most common. Coexistent congenital anomalies, cardiac, intestinal, skeletal, might be present simultaneously. Maternal hydramnios is present in 60% of the esophageal atresia. The effect of esophageal atresia on the infant is that saliva or later ingested material accumulates in the upper pouch and spills over into the trachea. Even more is the aspiration of the gastric contents and perhaps bile through the tracheoesophageal fistula into the bronchial tree. Pulmonary complications follow. Initially, there are areas of collapse and subsequent pneumonia may develop. Mild abdominal distension is often present is due to swallow down of the fistula into the stomach, and it cannot be arrested in the normal way. Early diagnosis, the most important aspect of esophageal atresia is that it should be recognized as soon as birth as possible, for any delay inevitably leads to progressive pulmonary complications. The chances of successful surgical treatment are to a large extent directly related to the length of time between birth and diagnosis. Pulmonary complications are very likely and with parallel with the prematurity and the effect associated with the delay with the developmental anomalies and inanition are the causes of death. Symptoms soon after birth. Fine frothy bubbles of mucus appears in the nostril and in the mouth. Feeling cause an acute episode of spluttering, coughing, and cyanosis. The affected infants are unable to swallow and typically present soon after birth with excessive mucus and cyanotic episodes exacerbated by any attempt to fill. The preceding pregnancy may have been complicated by maternal polyhydramnios. Passage of catheter number 10 French through the mouth will become arrested at about 10 centimeters from the lips. This can be demonstrated by X-ray. Gas in the abdomen indicates the presence of distal tracheoesophageal fistula. Contrast study demonstrates dilated upper pouch with spillage of contrast to the tracheoesophageal tube. Esophageal atresia, this is the radiology, the blind pouch of the esophagus, upper end of esophagus, you can see, and there is gas in the fundus of the stomach. Treatment, preparation for surgery. Surgery is the only treatment. Infant placed in suitable incubator, intravenous fluids are given, antibiotics are given, vitamin K is given. The upper pouch is kept empty by suction. Surgery, Through a right posterolateral extrapulmonary thoracotomy, the fistula is dealt with and continuity of the esophagus is resumed by the end-to-end anastomosis around the nasogastric tube. Postoperative care, these are the two ends of the esophagus which are discontinued and two ends of the upper and lower end of esophagus are communicating with the trachea. This is upper end is communicating with the trachea and the lower end is blind. The upper end is closed, is blind, and lower end communicates with the trachea. And in the second figure, the lower end also does not communicate with the trachea. These are the different types of tracheoesophageal fistula. Surgery for tracheoesophageal fistula is transthoracic repair is being carried out. These are the two ends of the esophagus are made to are anastomosed and continuity is restored. This is the operations being carried out by the gas in the fundus of the stomach. These are the four types of anomaly, tracheoesophageal fistula. Another variety of cause of dysphagia is dysphagia ligoria, where the subclavian artery compresses the esophagus. Tracheoesophageal repair is being carried out. Delayed repair can be done, but one has to take out gastrostomy as a measure to survive the infant, to salvage the infant. Where gastrostomy is being carried out and the child is being fed